Actually, the next topic is very, very, very important. As until yesterday, I had a patient who had been diabetic for 20 years, and he doesn't know anything about diabetes except his medications. So the coming topic will be about the diabetic or diabetes well-being. It will be given to us by Dr. Dalal Alromaihi, consultant endocrinologist at Awali Hospital in Bahrain. Please.
Thank you so much for your kind introduction. And indeed, this is a very, very important topic. So I'm a board member at Bahrain Diabetes Society, and I'm a member of the advocacy committee in the International Diabetes Federation. And talking about well-being for us is very, very important because yes, we are the scientists, the clinicians, but we're also the voice for patients. And we are the voice for doctors. We're all very busy in the clinic. And within seconds, we have to decide if the A1C target is achieved or not and what to do, give the best medication, blood pressure targets, LDL targets. But let's not forget that person in front of us, the person living with diabetes, so that we make sure that we empower them to live well with diabetes. And I selected this topic because, as you know, this is the theme of World Diabetes Day, and it is selected for last year, this year, and next year. So our message to all of us as a reminder of remembering that we're dealing with people who live day to day with diabetes. So in the coming 20 minutes or so, we will be exploring concepts related to diabetes and well-being, a reminder to myself and all of us. And I invite you all to self-reflect on your day-to-day practices in the clinical area, when you're teaching students, when you are with family members who live with diabetes, to remember these key concepts to help us be nicer, kinder, gentler, and more empowering of people around. So some of this has been already presented of the magnificent magnitude of diabetes that we globally are facing. And we're waiting for the latest IDF Atlas that will be released in April to see the statistics. The projection was from the IDF 2021 Atlas that by 2045, globally, we will reach around 780 million people living with diabetes. But the shocking numbers from the WHO released just end of last year is that we have already reached 830 million. So the number of people with diabetes is expanding, and us as a community, as a medical community, have to be equipped, prepared, and ready to deal with this increase in numbers. And we also have to still remember that all these millions are separate individuals with individual needs and burdens. What does the WHO define well-being as? So well-being is not being disease-free. Well-being is not being ill. Well-being is actually being well. And when we think of well-being, we think of three concepts: physical well-being, mental well-being, and social well-being. And we as clinicians build a strong foundation for physical and psychological well-being. We really lay the foundation for success, both in achieving glycemic targets and helping people have a better quality of life. We all see the standards of diabetes care and eagerly wait for the new editions. And we all see the decision cycle of person-centered glycemic management, and well-being concepts are there already in the concepts delivered. So we talk about individualizing priorities, we think about health behaviors, lifestyle, we think about assessing the patient access to care, cost of medications, availability of medication, etc. We explore personal preferences, we help with the shared decision-making, we think of their emotional well-being, lifestyle, and health behavior. But sometimes we really read, but we don't really look because we're overwhelmed with our clinical work, achieving LDL target, blood pressure target, A1C target. And all my presentation today is a reminder that we should again remind ourselves of that person living with diabetes. And during my presentation, you will see images appear of us in the Diabetes Society and the community work we do. as I explore these different concepts with you. So first, when we talk about physical well-being, I'll talk about two main things: nutrition and exercise, or physical activity. So the science of nutrition is evolving, and our knowledge and appreciation of nutrition is evolving. If you look at the standard of diabetes care in 1989, the word nutrition only appeared twice in the whole document, but we know how now it is a big segment of laying the foundation. And without good understanding of nutrition, the best medications there is will not be effective. And we also, with our knowledge of nutrition now, have migrated from talking about macro and micronutrients to talking about whole food. Because my patient doesn't want to know protein, carb, and fats. They want to know whole grain, salads, fruits, vegetables, etc. And we no longer say diabetic diet. I remember when I was a resident, when we admit a patient, we say, put the patient on a diabetic diet. And there's no such thing. There is healthier options and less healthier options. So when we explore the different diets that they are available right now, which ones will improve well-being to the max? The best in improving well-being with evidence in the literature is plant-based diet. These are associated with significant improvement in emotional well-being, physical well-being, depression, quality of life, general health, HbA1c, and not all of our patients can adhere with that. And as was said earlier, Mediterranean or DASH diets are fantastic alternative options. So if a patient asks you which diet to follow, if you could do plant-based or Mediterranean, that would not only help with their A1C targets, weight management, but also with well-being. Nutrition also is not only about what we eat, but how and when we eat. We in the region are enjoying religious fasting, but intermittent fasting or time-restricted eating is the new fashion now in dietary lifestyle around the world. And thanks to Dr. Hassanein and his colleagues who created the DAR guidelines, a lot of the knowledge learned from our region is expanded to time-restricted eating. The differences, however, between intermittent fasting and religious fasting are principally two main differences. With religious fasting, we don't drink water, we don't have hydration in the hours of fast, while with intermittent fasting, you have access to hydration. And the second difference is when we prescribe or when we go with religious fasting, you have fixed schedule. We're all fasting dawn to sunset. But with time-restricted eating or intermittent fasting, there are several designs. There are the 2 to 5, there are the 16 hours and others. So it's good to understand what the patient is doing. But common to both, as you see in the center, is both can subject your patients to hypoglycemia, so both need counseling, understanding how to guide the patient before and during the fast, and tweaking their medications. Moving to exercise and physical activity, we know that studies show that engaging in regular physical activity can lower blood glucose levels, improve insulin sensitivity. And we know from systematic reviews that in patients with chronic medical conditions, diabetes included, quality of life and well-being improves with exercise. So it's not something we just say because the ADA and the AHA says, but it is proven to improve well-being. And when we think of physical activity, everything counts. 500 extra steps on your pedometer counts. Interrupting your sitting. Maybe we should all stand once in a while in this lecture hall. Maybe you want to stand? I see some people wanting to stand. Yeah, your clocks, your watches didn't tell you to stand? Let's stand. 1 second. Yeah? Yeah? MashaAllah. We do that in clinic, yeah. We can do that in clinic. You just interrupt your sitting, as you see here, can improve your well-being and activity level. Not to forget resistance training. When we counsel patients about physical activity, we tell them to walk, we tell them to bike, we tell them to swim, but resistance training is also very important. And working on activities to reduce frailty and sarcopenia. The bulk of my talk really is not about nutrition or exercise. I decided to concentrate mostly on mental and psychological well-being because chronic stress can negatively impact blood glucose. We know from our encounters with patients that patients who are suffering from psychological disorders are at risk of diabetes, and then people with diabetes are subject to depression and anxiety. So what can we help them with? Mindfulness practices can help, meditation and yoga can help. And we know that it is not easy to live with diabetes, to think of your 2 agents, 3 agents for blood pressure, 2 agents, 3 agents for diabetes plus lipids, etc. So psychological factors can really compromise patients' adherence. I really enjoyed reading this paper that talks about the defense mechanisms that patients go through psychologically when they encounter a chronic disease like diabetes. So it's really looking beyond the visible. And there are several types of defenses, and I'll walk you through them. The first defense is turning against object. It's when the patient projects their anger about having to live with this chronic illness against somebody. It could be their doctor who first told them they have diabetes. It could be their spouse, and they are expressing anger. There is also projection. Projection is when there is, instead of taking ownership of, for example, missing their adherence to healthy diet, they will blame, because my wife doesn't cook healthy, she always adds butter, she always serves me high carb diet, or the management is not providing good options in the canteen, etc. It's always somebody else's fault, no ownership, always projecting. Then there's principalization. It's those people who can separate their thoughts from their feelings. They know they make mistakes. They're okay with that. They don't go through a lot of self-guilt about diabetes. And they are probably your best patients who have good understanding that this is a chronic illness and it's okay to have some lapses from time to time. There's turning against self, which are people who would say, I'm guilty. I got my diabetes because of my previous bad lifestyle habits, and I deserve what happens to me. And they would allow themselves, as a part of self-harm, to have negative outcomes. Then there's reversal, or we can say denial, and everything is fine. Even if my A1C is high, I don't feel it, it's not affecting me. These doctors are telling me things. And our job is to guide patients or identify those who are struggling with the other types of defenses, to refer them to proper support to understand their feelings and emotions. Because you know and I know, and we sit in the clinic and they come month after month and 3 months after 3 months, no progress. They take their medications and they don't take them, but if we don't invest the time to find the root cause and help them, we'll not make progress. And the main concept that I also wanted to emphasize on today is diabetes distress, which is totally different than depression. Diabetes distress is the burden of carrying diabetes on your shoulder day in and day out. Think of somebody, for example, with type 1 diabetes who has to plan their menu, think of what to pack, think of what to take, think of checking their sugar, think of their injection. So diabetes is always there in their radar, and that can be overwhelming and a struggle. And in a study that looked at the distribution of people with diabetes distress among people living with diabetes, around 20 to 30% have diabetes distress, and it's not a small portion. And there are validated tools that you can have and you should have in your waiting area to assess for diabetes distress. And you could also find in your clinical area that you have patients who have diabetes who are depressed, maybe 5 to 10%, and some who are depressed and distressed. But luckily, 50 to 70% of our patients are none. And if we look at traits, which ones among our patients are more likely to have diabetes distress? It's your patients with type 1. Obviously, it's a more cumbersome disease to live with. Women are vulnerable to distress. Younger individuals, and early diagnosis. So until they learn how to cope and learn well with diabetes. And who are the well ones who are okay? Usually those who have good social support. So if your patient comes with a friend, with a sister, a brother, a parent, that is also very important to appreciate, to value, to direct your conversation and eye gaze to, because they are their network. The example we've heard from Dr. Kins about the guy's brother was better than terzepatide. That was a very good brother. So having a good social network and guiding the patient to that is also very helpful. Of course, there are patients that we can help, but we don't have the time, or sometimes we don't have the knowledge and the tools and the expertise to guide them. But at least if you pick that a patient may be having an eating disorder, obviously having fear of hypoglycemia, before maybe and after undergoing metabolic surgery. So the ADA puts clear indications where we should refer, and these are very valuable members of our team, psychologists who have good experience with diabetes. A lot of what we know about diabetes and mental health and depression comes from our colleagues in Desman. Dr. Ibal Ozeri and colleagues looked at this in a cohort of subjects with type 2 diabetes and found that some had pre-existing depression, but 30% of participants here were picked up as having evidence of depression in the study. I'm replicating her study now at my clinic at Awali Hospital, and I'm evaluating specifically diabetes distress because I think this is an under-investigated matter in our region. So moving to social connections, that's extremely important, so to enhance mental health and encourage positive behavior. This paper here looks at understanding the integration of social context and diabetes care. And when we think of earlier I said there is physical well-being, there is mental well-being and societal well-being, where really the big picture is also as important as the one-on-one interactions. So having community support, what are we posting on media, policy, all of that is needed because that's the big picture, a network to support patients. And this is something I'm proud of when we work with the Bahrain Diabetes Society and all the activities we do for the subjects living with diabetes or people living with diabetes, their families, their communities, that's what we're looking for. And there's very little research on how to guide people with diabetes to cope with challenging environment, so stigma, bullying, and such. But what we could do is empower them to address such social context and empower people around them, their support network, to help guide them in these difficult situations, especially with stigma and myths. In societal well-being, community support, as I said, is important. You see here His Excellency Sheikh Mohammed bin Abdullah Al Khalifa. There is leadership like from Babco and Awali Hospital, and we go around, we walk around, and with a lot of members from Bahrain Diabetes Society and the community and other hospitals, because we think it's crucial to set role models, to engage in physical activity, and to make it fun, and to make it a remember experience so that people can engage in physical activity year in and year out. Because even if they go through remission, diabetes is not a one-time thing, it's a lifetime journey. You met Dr. Mariam Al-Hajri this morning, and one of our activities is going to shopping malls, talking about diabetes, etc. But this year in our stations, we included a station for well-being and for social and societal support, because we think, and I'm sure in different countries it's the same, there are so many areas that can support people, but people sometimes don't know access. And we also care about youth and teaching youth at young age, even the healthy kids, how to maintain healthy lifestyle to avoid childhood obesity and avoid future burden of increasing type 2 diabetes. So we call to action that every small step counts. Listening to me today counts if it sparked an idea that you can apply in your clinical area, your clinical context, or in your family member. But we definitely need more solid research within our region on well-being, on, for example, the mental health, diabetes distress, etc. And I hope this presentation just helped inspire you. Remember a few key concepts: that nutrition matters, that there is no such thing as a diabetic diet, but we think of food, whole food in general, that physical activity matters and it improves well-being as shown by research. And mental health should not be a back thing, it should be a frontline priority for all of us. Diabetes distress and depression are not the same, And social support is really a key for successful care. So let's commit that all of us can make a difference in well-being to make it a priority in both our care and research. Thank you.
Thank you very much, Dr.